version was essentially related to Down syndrome screening, and now we are covering 5 aspects. The importance of the first trimester scan relates to confirming viability and checking plurality. This is particularly important because nowadays we have the cell-free DNA test, the non-invasive prenatal testing, whereby I'm sure you hear stories about women pitching up to a clinic with a encapsulate at 20 weeks because they no longer go for a first trimester scan, they go directly for a cell-free DNA test, which does not obviously rule out encapsulate, and therefore women are turning up to a clinic in the mid-trimester with major structural anomalies. So in this day and age, this is extremely important for us to focus the importance of doing this comprehensive 11-14 week scan. You obviously need to check viability before proceeding with cell-free DNA testing. You need to check plurality, meaning whether it's a singleton pregnancy, a twin pregnancy, or triplet and beyond, a high order pregnancy, so that the care plan for the whole pregnancy will be according to whether it's a twin pregnancy or triplets, etc. Accurate pregnancy dating. I know you would think that I'm being very, very elementary, but you will be surprised that in our specialty, obstetrics and fetal medicine, the most difficult concept is dating a pregnancy. Do you know the best way of dating pregnancy? You think you know, but actually you don't. And in the UK, the recommendation is that actually every pregnancy should be dated according to fetal chromosome length, measured at 11 to 14 weeks, because it's a well-defined time point, and also there's a well-defined method of measurement. And yet, the rest of the world is still going with the last menstrual period, give or take, because we are always a little bit forgetful, and you know that sperm can survive for 7 days. And therefore, actually, if you think you know when pregnancy has occurred, the conception has occurred, then I think we are really missing the point. We need to really kind of date the pregnancy according to primary. The annual screening, I will bring in the concept of combining cell-free DNA testing together with the ultrasound scan. And what is new is in relation to major structural anomalies, and as well as predicting preterm preeclampsia, which is a topic that is very close to my heart. And tomorrow I'll share with you our latest results. And this guidance aims to provide advice for healthcare practitioners performing or planning to perform pregnancy scans at 11-14 weeks. There are some general considerations. It has to be done at 11-14 weeks. That's very, very simple because this is how our guideline was drafted. You need to have had specialized training, and if you are planning to get trained, fantastic. You are also very welcome to read this guidance. And you need to remember the machine that you require is of a certain level. It has to be high quality and also has to be under regular maintenance and servicing. And the middle point is extremely important, documentation. How you write the report. I think it relates to the legal side, yes? And within the guidelines, we have proposed a format as to how we can report on the structural abnormalities and so forth. You can do it electronically or on paper, because sometimes you will get referral from other centers and you must return the patient with documentation. And safety, luckily ultrasound is very safe, but in relation to safety, I want to highlight the concept of ALARA. ALARA is as low as possible, meaning that if you don't need to use Doppler, don't use it excessively. Once you are absolutely certain that you're in the right anatomical landmark, then you can turn on color flow mapping to measure the ductal stenosis. And I respect local circumstances for adopting the guidance. Just because we have a guideline, it doesn't mean that you have to completely follow every single aspect. You need to take out bits and bobs and fit it within your local practice. You need to justify, not because I feel like I want to measure this. You have to have reasons and justifications as to why you're not adopting the evaluation of fingers, why you're not adopting the evaluation of cord insertion. You need to have that justification. Multiple pregnancy relates to, as I mentioned, chronicity and amniosity, and that's important in relation to the subsequent management, etc. So I will not dwell on this slide because I've already touched on the importance of viability. You should confirm that it is an in utero ectopic pregnancy. What do I mean by that? Have you seen a case of ectopic pregnancy being detected at 20 weeks? I'm sure you have. This is because you don't make an effort to trace the cervix to the intrauterine environment to see whether the gestational sac is indeed within the uterus. And this is extremely important for you to remember. You need to check the pregnancy is indeed intrauterine. You also need to check for uterine integrity, especially in cases with previous history of cesarean section. And we are here recommending the measurement of fetal barometry, not because we are really saying you must measure, except fetal chromosomal length, except BPD. So fetal chromosomal length is the first and foremost very important measurement, okay? And then the second is BPD. And then for us to recommend the measurement of AC, we are acknowledging the fact that all these normal graphs are perhaps not up to date, but the fact that when you're measuring the abdominal circumference, you will check the anatomy. You will check that the stomach is in the right place. You will see that there's an umbilical vein. And then we are recommending female length measurement. And then why do we say that? It's because it pushes you to look at the 3 segments of the leg. Yes, you will check the femur, you look at the tibia, and then you look at the ankle. So this is what we are proposing here. You measure the fetal barometry in order for you to check the anatomy. We will acknowledge that visualization of many anatomical details by ultrasound is best achieved at around 13 weeks of gestation. Sorry, this is a very strong light, and I can't even read my next slide, so I'm going to adjust a little bit. So we acknowledge that 13 weeks is best because the fetus is more developed, and also I appreciate that not everywhere can do a scan at 13 weeks, and you want to provide downstream syndrome screening at 12 weeks, pericardial screening at 12 weeks, and then how we're going to do everything in one go. But on the other hand though, given that our patients are thinner in Asia, so I think 12 weeks and 5 days is the best. That is 65 millimeters in terms of common length. So in relation to assessment of fetal anatomy, we have come up with 2 levels of screening: basic screening and then comprehensive screening. Basic screening means that if you provide cell-free DNA testing, you still need to do the scan, and we expect you to have checked head to bottom. We're expecting you to have to check the head and brain. Within the head and brain, you need to check the head shape, ossification. You need to see the midline pulse is present. You need to see the butterfly-shaped coral plexus is present. And then you sweep down to the heart. You need to make sure the heart is in the intrathoracic position, is not outside, there's not pentalgic contrail, and then you check for regular rhythm. And then sweeping down on the abdomen, you need to see that the stomach is present, the abdominal wall is intact, you should see the insertion of the cord. Then sweeping down, we go to the bladder, which is not dilated. And also, the presence of the bladder reminds you that the kidneys are present, or at least one kidney is present. Then extremities, as I mentioned, we are suggesting that you measure the female length, so that will lead you to evaluation of the lower limbs, and making sure that there are 3 segments. Not asking you to count toes and fingers. However, if you see one feature of abnormality, such as an exomphalos, automatically you should be looking for polydactyly. So, as a screen, we're not asking you to count toes and fingers, but if you start seeing abnormalities, then you should make an effort to count toes and fingers, okay? And then when it comes to placenta, I want you to look at the appearance, making sure that it's not cystic. So I will go through the best practice in detail because it's very heavy. And I want to remind you that best practice means best practice, and you do the best as you can. We obviously cannot see everything at 11 weeks, but at 13 weeks plus, you'll be able to see everything. And if you cannot see something, we're not going to penalize you. You can say that you do not see it, okay? Because you have to justify, however. You can say that because of maternal habitus, because of maternal obesity, because of maternal scar, fetal position. You have to justify. I'll go through the best practice step by step. So the first thing we would want you to do is when you put the transducer on the abdomen, you need to have an overall view of the pregnancy. Confirm that it's a singleton pregnancy or twin pregnancy and so forth. You have to have an overview. Overview meaning what I tend to do is basically I put the transducer. You can see the full length of the fetus, measure the fetal column length. You sweep left and right. So making sure that you do that, and also you do transverse plane, and then you sweep up and down as well. Making sure that you check the placenta, check the fetus, and cord insertion, etc. You also need to look at the ovaries and look for any fibroids. But in the event of previous scar, we'll talk a little bit about that. In relation to fetal anatomy assessment, I'll go through this step by step, so do not worry. Head and brain. I'm very systematic in my clinical practice, and I do that in my clinic as well. But I also appreciate that the feeders will be opportunistic, will show you bits and pieces, and you will need to be, flexible. I don't know when I say I want you to start with the head, but if the fetus shows you the heart, go to the heart. Don't miss the opportunity, because I know you don't have all day. Time is precious, and you have a very heavy clinic, and therefore, while you are trying to be systematic, you also have to be opportunistic. With head and brain, you need to use a combination of axial and mid-sagittal planes. And then here you can obviously use you can see this is axial plane, you can see the midline faults, you can look at the calcification of cranium, and if in doubt, you can always put a bit of pressure on the abdomen, and you will see whether there's indentation of the skull. With that, you might suspect that this is reduced ossification. When you see the coral plexus, making sure that the butterfly almost fill the lateral ventricles, and if it's reduced, meaning you see more black than the coral plexus, I don't immediately think of ventriculomegaly, but you need to have that suspicion. So when you look at the rest of the figures, you may want to see whether there is enlarged brainstem, because you worry about open spina bifida. Okay, and then you sweep down. You can see the two thalami. You can see the posterior fossa region. You can see the cerebral peduncles, aqueduct, sylvius, fourth ventricle, and the future cisterna magna. So this is how you sweep down, and then you can look at the posterior fossa. I think this is more challenging at 11 weeks, but certainly I see that most of our patients here are thinner, and 12 weeks onwards you should be able to visualize the fetal anatomy relatively well. While you're on axial plane, you basically turn the transducer into mid-sagittal plane, and I think most of you will be very familiar with this plane. This is the most important image of every single pregnancy, whereby you will be able to assess a number of conditions. In addition to the measurement of fetal nuchal translucency, you'll be able to appreciate the forehead, the nasal bone, the skin covering the nasal bone, the tip of the nose, the palate, the chin. Then here you see the midbrain, you see the brainstem, you see the posterior fossa. In the event of ulnar-Chiari malformation, then the brainstem will be enlarged. You'll get a compression of the posterior fossa, and suspecting open spina bifida. And then with this, you can actually really rule out a number of conditions. And then twisting your transducer to the coronal plane, you'll be able to appreciate the eyes and the lenses, and moving the transducer forward. I think I'm putting myself in that kind of, I don't know whether you can see my profile, and you go for the coronal plane, and moving it forward, you'll be able to see the retronasal triangle, demonstrating the maxilla and the mandible. So when it comes to the fetal profile view, just a reminder that I do not advocate replacing the measurement of fetal NT with cell-free DNA. I actually see a lot of this happening in Hong Kong. If a patient has a cell-free DNA test booked, they don't automatically get an NT scan. And every pregnant woman gets a free NT scan in Hong Kong. And I'm seeing that, and I get very frustrated, because I think the combination of the two is extremely important, because increased NT is also associated with rarer aneuploidies and structural anomalies. And therefore, we need to consider what we call the false positives, the 5% are perhaps also useful for screening other chromosomal abnormalities, rare genetic syndromes, and structural anomalies. So this is completion of the evaluation of the face and brain together, and then the neck you can appreciate, and then the moving down now. So you basically sweep down, you get the thorax, and then you need to appreciate the shape of the thoracic wall. And that actually also do us, as I said at the beginning, when you do a sagittal plane, I think you will immediately be able to appreciate a pear shape. When you have a smaller chest with a bulging abdomen, a pear shape, that immediately reminds you that there could be skeletal dysplasia, yes? And then the transverse view, you will be able to see a small thoracic wall, and then, or abnormal shape. Sometimes you get also a bit of pear shape here as well with the indentation of the ribs. Lung field should be more or less symmetrical, and you'll be able to appreciate the diaphragmatic continuity, okay? So being systematic still, and now at the same time when you evaluate the thorax, you also check the heart, making sure that of course there's heart activity. I think sometimes this might be the first thing you want to do when you start to scan, making sure that the fetus is viable. Because obviously sometimes you show too many things and then to realize this is a miscarriage. It can happen because you get overly excited about seeing the fetus and forget to check fetal viability. Okay, heart rate is evaluated. You need to establish situs. Even at the 11-14 week scan, you need to make sure situs is correct. Left is right, right is right. The position of the heart, making sure it's interthoracic, and the axis should be within 30 to 60 degrees to the left. You can obviously draw this angle, yeah, with the machine. They have an angle ruler. And then in evaluation of the full chamber view, you should be able to see these two distinct ventricles on Gray scale and color Doppler in diastole. Okay, you will see the equal filling and equal filling of the ventricles, and then you will be able to also tilt the transducer towards the fetal head. This is how you get the outflow tract view. This is exactly the same as doing maternal adult echo. So full chamber view, tilt the transducer towards the head, then you'll be able to get the outflow tract, and then you can also evaluate outflow tract on the Gray scale or color Doppler. And sweeping up, then you'll be able to do the 3-vessel trachea view on Gray scale or color Doppler. And color Doppler, essentially, you'll be able to see the V shape with the trachea here and the SVC on the right. And then you appreciate the absence of tricuspid regurgitation, as well as the ductus venosus A-wave evaluation as part of your anatomical evaluation. Then sweeping down, you go onto the abdomen, and then stomach should be on the left, and then you need to confirm situs, and sometimes it takes a bit of orientation when you start the scan. I know you tend to do it in the mid-trimester period, mid-trimester scan, and so, but you need to remember that even in the first trimester, you need to do this. Then sweeping down, you will be able to appreciate the bladder as the black bubble here, and I will also check for 3 vessels in the cord. Then turning to the coronal plane, you get the kidneys. Nowadays they are very visible, and then in the past they were not visible. We take our present bladder as presence of kidneys, but we can actually evaluate the kidneys very well. And then in relation to bladder, as you know very well already, you need to make sure it's not enlarged, it's less than 7 millimeters. Going down to the abdominal wall, I think I've already mentioned the need of evaluating cord insertion, making sure you don't miss a gastroschisis on phallocele, but you have to appreciate that up to 11 weeks you can have physiological herniation. So I don't know whether you have a system whereby if you see somebody too early at 11 weeks and you see on phallocele, you would definitely have to bring her back a week later to make sure that you're not doing an unnecessary CVS. Okay, and then cord insertion, I mentioned, and checking the number of vessels in the cord, making sure there are 2 arteries, and I tend to use power Doppler, okay, because I think color Doppler is less sensitive, and making sure that you evaluate this because SUA is associated with congenital anomalies, particularly cardiac abnormalities, as well as renal, and also it's also associated with fetal growth restriction. The spine, you start with the sagittal evaluation of the fetal profile. You look for the intracranial translucency, and then, but on the other hand, though, I tend to evaluate the spine even without evaluation of intracranial translucency. But I would appreciate the regular shape and and continuity of the spine. If you think there's a high suspicion of open spinal bifida and be necessary to do a transvaginal scan. I've already touched on the importance of checking the limbs of the 3 segments. The placenta is important, and also chronicity is important. And then the role of 3D ultrasound, 4D ultrasound at this day and age. We're not recommending routine use as part of the evaluation, but I think with Zuko will show you beautiful images later on with lots of 3Ds and 4Ds. And then, but I think this is additional beyond the recommendation of our guidelines. Common and employee screening, we now have 2 options: combined first trimester screening, combination of fetal NT plus serum biochemistry, and then cell-free DNA testing. We all appreciate that cell-free DNA testing is by far the superior test, but I'll give you the different combinations and in relation to the screening performance. Fetal NT, I will not dwell on this part because I think most of you will be very familiar with how to measure fetal NT, and the presence or the absence of the nasal bone. This is extremely important, and then the length of it is actually debatable, but certainly making sure that the nose bone is as bright or brighter than the overlying skin is important. And the ductus venosus flow, you can see that this is umbilical vein, this is ductus venosus, and sampling it, making sure that the airway is present. And for TR, when the heart apex is pointing 12 o'clock or 6 o'clock, then you'll be able to appreciate the flow across the tricuspid valves. Then, in terms of screening performance, this is rather busy, but the most important thing is using this combined test, as you can see. NT, serum biochemical markers, then you can actually predict a large proportion of cases of trisomy 21, 18, 13, and Turner syndrome. But the most important table is this one, because in my practice, I will be recommending the 3rd option. I would like to do combined cell-free DNA together with an 11-14-week scan, whereby I actually evaluate the anatomy as well as measurement of fetal NT, because it achieves 100% detection rate at a 0.1% false positive rate. And in your practice, if you take a big NT greater than 3.5 millimeters or anomalies as an indication for invasive testing, then I will shift the false positive rate to 2.5%. I think this is still very respectable. And in relation to trisomy 18 and 13, 100% detection rate. So for me, this is best practice. And then if resources are limited, and then you will do the combined screening first, followed by cell-free DNA as a contingent test. So placental abnormalities is important. At that moment in time, please don't miss a case like this. This is basically ectopic pregnancy, but not quite. It is cesarean section scar pregnancy. It's basically the pregnancy is in the bladder, and you can really miss this if you don't look for it. And you should pay attention in the case of prior cesarean section, and then you should really evaluate placental integrity, uterine integrity. And in my last few minutes, of course, I will touch on pericardial screening, which is the precursor to my talk tomorrow. And here, the use of ultrasound has a very important place, combining ultrasound marker, uterine artery Doppler, with placental growth factor, blood pressure, and a number of risk factors. We can predict a high proportion of early onset and preterm preeclampsia in comparison to history-only screening. And with this is the guidelines as to how we measure. I will not focus the details because I think most of you will be very familiar with this. But then if you need to take a picture of this, the most important thing I want to remind you is making sure you recognize the anatomy. Don't zoom right in. You need to be able to see the bladder, the cervix, and the uterus, fixing the transducer in the midline, and then gently tilting the transducer to the side of the cervix, because you know the 2 vessels are to the side of the cervix, and then with color fill mapping, and you can visualize the uterine arteries very nicely. You need to do this slowly because the cervix is not big. If you do big movements, you will miss the vessels. And color Dopplers will take a bit of time to show up. So, maybe with a new machine, with a beautiful machine, that it will be very, very easy. But if you are using an old machine, a mid-range machine, you need to give time for the Doppler to show. And lastly, of course, once you find a high-risk woman, you should give aspirin, and then this will hopefully prevent a large number of cases of preterm early onset preeclampsia. And to finish off, just to demonstrate, this is the step I take. So you look at the midline folds, the coral plexus, and then you also evaluate for the third ventricle, and then sweeping this plane, the coronal plane. You look at the eyes, the sockets, eyeball orbits, and then the lenses, and then earlier you already saw the retrograde triangle, the hands. I mean, I would love to count the fingers, but I'm mindful that not everybody can count all the fingers in your setting. Making sure you check sinus, the stomach, and then when you evaluate the full chamber, you make sure you use color Doppler to look at the visual filling of the ventricles, and sweeping out either for the V sign for the pulmonary artery as well as the aortic arch, and making sure you check the position of the trachea. The sagittal plane is extremely important. I tend to do what we call sweeping sign, and then afterwards, of course, you will be able to visualize this perfect mid-sagittal view of the facial profile, whereby you'll be able to evaluate all the different components of what we talked about already. So, and sweeping on one side to the other, and you can appreciate the diaphragm. Don't forget to sweep to the other side. We've had missed cases of congenital diaphragmatic hernia because you just looked at one side, not the other side, and so you miss a case like that. And in relation to the extremities, you appreciate the ankle, and you also appreciate the footprint as well. And kidneys, beautiful kidneys you can see nowadays, and to visualize the vascular journey, use of power Doppler is helpful here. The spine, I also tend to do this as the first stage of screening, and then abdominal wall, you can appreciate the core insertion, etc. So, and then in relation to field sex genitalia, we also recommend if you can try and take a look. So, to finish off, you can scan the QR code that takes you directly to the guidelines, and these are ways of contacting me if you have any questions. Thank you very much for your attention.
Tiếp theo là các rối loạn di truyền từ thai đến được 83 tuần. Xin mời báo cáo viên giáo sư Richard Copua.
Hello, everybody, and I came back. The Ho Chi Minh is my favorite city, and I'm very happy to see you all. And today, the first talk is about genetic disorders between 8 and 13 weeks of gestation. And but before the 8 weeks of gestation, I'd like to talk about the twins, the very shortly. And this is a blast site, and blast site is the 5 days after the collecting eggs. And usually when you see the trophoectoderm, TE, and inner cell mass inside of the egg. And the trophoectoderm is going to be the placenta, and inner cell mass is going to be the baby. Okay? So usually if you take the amniotic cells, this is from the inner cell mass, and the CVS, you can take the trophoectoderm origin. Now, usually you think that dizygotic twin and monozygotic twin, and many of the OBGYN doctors, I'm not quite sure in Vietnam, but in Japan, many of the OBGYN doctors, they say that the dizygotic twin is going to be the DCDA twin, and the monozygotic twin is going to be the monochorionic twins. Mostly it is right? However, sometimes the monozygotic twin is going to be the dichorionic twins, and also here you can see this is the chronicity and the amnionicity at 8 weeks of gestation, and you can see here this is the DCDA twin, and this is the MCDA monochorionic twin, diamniotic twins. And you can see here you can see the two are the chorion and the two amniotic membranes. Therefore, know that there are 4 membranes in between the two babies. And in the contrast, the MCDA twin has the 2 amniotic membrane, no chorionic in between. So there you can see the 2 membrane between the 2 babies. Okay. Sometimes we can see the conjoined twins, and sometimes we see the cardiac twin. But today, I would like to talk about the twins and the CVS. And CVS, usually you do the CVS twice for the DCDA twins. And also MCDA twin, monochorionic twins, we can do CVS once, right? And then in my place, we do the QFPCR, and we can confirm the zygosity of the twins. And then we have so far the more than 11,000 QFPCR, and then we had the DCDA twin 191 and the MC twin 79, and we do the CVS twice, for the 1 by 1, and then we divided into the spontaneous plus AIH and IVF plus ICSI. And then here you can see the DCDA twin has a monozygotic twin, 21% from the spontaneous pregnancy, but IVF ICSI, the monozygotic twin is only 5.2%. And interestingly, here you can see this is the MC twin, monochorionic twin, but there is a dizygotic twin. And I would like to show you here, that this is a case, the very unique case of MD twins. The ultrasound image at 12 weeks of gestation clearly depict the 1 chorion and 2 amniotic membranes. And it was, however, it was suspected that fetus A is a girl and fetus B is a boy. What is happening? And then the QFPCR shows the 2 cell lines, and the CVS fish shows the XX and XY, the almost 50-50. And then the boy and girl from MCDA twins. So in this case, the 2 blastocytes implanted very close to each other in the uterus. However, only TE would be chimera, and 2 fetuses would have come from their respective the ICM in the cell mass. So the CVS just harvest that the chimera portion of that placenta. Now the number 2, the case number 2 is the 2 IVF blastocytes were implanted, and mother has balanced translocation 11 and 12, 22. And CVS result was like mother, but balanced translocation. Okay, so we did the 1 CVS, and then one day after delivery of the babies, mother called us and said that after birth, no matter how I look at their faces, but their faces are quite different. Are they really identical twins? Oh my gosh, please come. And then they come. And exactly, they are the different faces, right? Like dizygotic twins. So what we did, we draw blood from 2 twins, and we use a power pricks to identify the individuals. And then the result were the presence of the DNA derived from 2 cell lines in both individuals. And karyotyping result was both twin has mosaicism of the balanced translocation and normal. So this is called the blood chimera, and the 2 blastocytes implanted very close to each other when 2 blood cells were interchanged via placental vascular anosmosis, like TTDS, right? and the blood stem cells from one the stem cell line grow into the other and forming the blood chimera. So again 2 eggs and 1 TE and 2 ICMs, and then the first case the placental chimera, but the second case mutual exchange of the blood cells, so the blood stem cell settle on the other. So the why we diagnose it like this, the blood chimera, is because the serious result was the leg mother. This is the translocation, the branch translocation, and finally we had the mosaicism in both fetuses. So therefore, another child who did not originally inherit translocation in 46XY. Richard, do you agree with me? Okay, so the next one is abnormality at 8 to 10 weeks of gestation. First, the yolk sac. The yolk sac is usually, the 2 to 5 millimeter, and this is 4 weeks and 5 weeks of gestation. And here you can see the yolk sac and small embryo, and then at 6 weeks of gestation, this is the yolk sac and this is the embryo. However, sometimes that we see the large yolk sac like this. That this is a normal and this is a large yolk sac, and sometimes here that this is the yolk sac at 7 weeks of gestation. In him, you can see the fetal heart rate here, and the embryo was 4.8 millimeter, but the yolk sac was 8 millimeter. So it's actually that this is a very large yolk sac. Okay, and this is a 47XS plus 22. So this baby or this embryo died 1 week later. And this is also the large yolk sac at 8 weeks of gestation. This also the IFT, the infected fetal demise. So abnormal size or distorted shape of the yolk sac, the abortion rate, and also the chromosomal abnormality rate is very high. Now, the small fetus at 8 to 10 weeks of gestation, usually, some of you are the IVF clinic or hospital, right? And maybe, many of the pregnant women graduated from your clinic, that around at 8 to 10 weeks of gestation. And here, this is the 9 weeks of gestation, ICSI pregnancy, and then the CRL was 19.1 millimeter. This is like 8 weeks of gestation minus the 3.4 standard deviation. And here inside of the brain, this is very, very abnormal. The compared to the normal, you can see only one the brain here. So this is a holopus encephaly, the very early stage. This is also the CRL 26.2 millimeter and very small baby at 10 weeks of gestation. And this baby also has the prosencephalon only one compared to the normal, the 2 brains. So this is the early stage of the holopus encephaly. And sometimes in the small baby includes a trisomy 18 baby at 9 weeks of gestation, and sometimes the trisomy 18 associated with the holopus encephaly like this. But not only the chromosomal abnormality or genetic abnormalities. Sometimes that you can see Down syndrome, and this also was included in the small babies, and acrania like this, and anencephaly, and the maybe after later the second lecture I will talk about the BSA, but the small baby includes the chromosomal abnormality, brain abnormality, and amniotic Down syndrome and body stack anomaly. Now the next one is the 2 black shadows on the fetus's body. What is this? 2 black. Here you can see the 2 black part here inside of the fetal body. Have you ever seen this? And this is the pleural effusion. And the pleural effusion at 8 or 9 weeks of gestation, here, that this baby, 5 days later, the intrauterine fetal demise. And then the chromosome was the 15, trisomy 15. And next one, this also has the black shadow inside the body. And this one is a 45X Turner syndrome. And here, this one, the 10 weeks, also, the very, the large black shadow inside the body. And this one was the trisomy 15. And this is the large yolk sac. Okay? So usually, the large yolk sac, sometimes, that you can see the autosomal trisomy like this, and the chromosome 15 or 22 or others. And the normal yolk sac, but the black shadows there, the Turner syndrome. Now, the 11 to 13 weeks of gestation, I try to talk about the trisomies later on, so I try to talk the non-trisomic abnormalities. And here, this is in my institute, we do the 11 to 14 weeks scan. Of course, that we do the nuclear translucency, the nasal one, and we can see the tricuspid regurgitation and fetus venosus flow. And we also, observe the loss at ear, the micrognathia, and without focal anomaly scan. And here, we do the first primary scan and the CVS normal karyotype, the second follow-up scan, and then for the selected cases, we do the exome sequencing. And now we have the data here that the abnormal chromosome or gene variant 955, out of the more than 8,500. So it is 11.1%, and including the trisomies 596. It means the 360 cases they are non-trisomic abnormality. And then in there the pathogenic CMV and pathogenic the gene variants, those are occupying the 15% in total. And those are detected by the SNP microarray or exome sequencing. And we did the exome sequencing for the 263 cases, and we had the monogenic variant in 33.2%. And here, this is a very busy slide, but 78 cases of the likely pathogenic or pathogenic variants. And the mostly, they are grassopathies, the Noonan syndrome and others, and skeletal abnormalities, multisystem and brain, and the muscular and others. And then, so we look at the genetic variants and the nuclear translucency thickness. And here you can see the divided into 4 groups, and I would like to show you here, this line, the yellow line, is the nuclear translucency of 3.5 millimeters, and over 3.5 millimeters in nuclear translucency, you can see the genetic variant was the 40%, and below 3.5 millimeters, the genetic variant was 21.1%. So still, if you look at only the nuclear translucency, it is quite difficult, to detect those genetic variants. And when to proceed to genetic testing, the whole exome sequencing, that is the indication is the ultrasound findings. So I need I said, and also the Leona told about the anomaly scan, very important. And then So whether the nuclear translucence is thick or thin, it is important to look at in detail with ultrasound. So the anomaly scan at 11 weeks of gestation, 11 to 13 weeks of gestation, you can see the ear position or micrognatio, or the head shape, or inside of the brain, and the general stature, or the wrist contracture or any other. And also we do the follow-up scan, and especially that we are looking at the brain, and also like here you can see the contracture, the general contracture or limb contractures. Sometimes that we can find the genetic variants. So as I showed you, the below the 3.5 millimeter of the nuclear translucency, we have still the many of the genetic variants in them. So the indication for the genetic test was the ultrasound findings. And finally, I would like to talk about the early detection of the Joubert syndrome. I don't think that the many people here know about the Joubert syndrome. But Joubert syndrome is a ciliopathy, one of the ciliopathies, and it is not of the brain abnormality, but the general abnormality, not only the brain, but general abnormality. And I published the open isthmus and the lambda sign of the early Joubert syndrome. And usually, the early Joubert is very, very difficult to detect. But the Joubert syndrome, usually, the most common communication nowadays, between the radiologist and pediatric neurologist is like, like this. This is a molar tooth sign by the radiologist, and then the pediatrician said, so it is a Joubert syndrome. So the Joubert syndrome and molar tooth sign is almost the same, interchangeable words. And what is a molar tooth? Molar tooth is here, right? So everybody has a molar tooth. You have molar tooth, right? And here, this is the molar tooth. And what is a molar tooth sign? This is a pediatric MRI findings. And if you look at the brain by MRI and actual brain, and usually the normal is like, the brainstem is like this. However, the Joubert syndrome is like here. You can see this is called a molar tooth sign. And the prenatal diagnosis is very difficult. Okay? The prenatal diagnosis is very difficult in the late pregnancy because the bilateral cerebral lobe typically and kissing each other in major part due to the Burmese hypoplasia in late pregnancy. And however, the early pregnancy, the prenatal diagnosis is also difficult because the molar tooth sign is not created yet. And we have 5 cases here that those are 3 cases of the Joubert syndrome, and we confirmed the responsible genes. And we look at the brain, and this is the case we showed longitudinally from 12 to 19 weeks of gestation, and we did the autopsy, and at 21 weeks of gestation, still, the molar tooth sign is very, very premature. This is a baby molar tooth sign. So at this stage, the molar tooth sign is not completely created. So therefore, we don't say that that these findings don't say the molar tooth sign, and because the molar tooth sign is as I told you, the actual sign of the superior cerebral, the peduncle, like here, the roots of the molar tooth. So I would like to talk about the lambda and omega, and usually normal here. This is the aqueduct. This is the fourth ventricle, and here you can see like the omega sign. And here this is the real ultrasound scan, and here you can see this is the omega sign, and this is the normal. And however, Joubert syndrome, you can see this is the open isthmus. This is the open, and the aqueduct, the fourth ventricle, they are continuing with each other. So here you can see this is like a lambda. So the lambda sign is the sign of the Joubert syndrome in our pregnancy. So is this Joubert? Not sure, right? But here you can see this is an omega, not lambda. So this is not Joubert syndrome. Actually, you know that this is the collagen 1 alpha 2 gene variant. This is one of the osteogenesis imperfecta. Now, as a conclusion, the many abnormalities can still be identified around the time of graduation from the fertility treatment at 8 to 10 weeks of gestation. And at 11 to 13 weeks, many abnormalities can be detected, not only by nucleotranslucency, but the ultrasound markers, but also by detailed observation and follow-up scan. Thank you very much.
Cảm ơn cô, và bài cuối cùng trong phiên 1 là bài vai trò của NIPT trong tiên đoán và chẩn đoán bất thường thai quý 1. Xin mời báo cáo viên giáo sư Richard Choi tiến lên hội trường.
Good afternoon, everyone. After the two excellent lectures from Professor Leona Punt and Dr. Liz Pu, what I'm going to share with you for the next 25 minutes is more regarding what's the new development of non-invasive prenatal testing. I'm going to introduce what have been done in Hong Kong first, to share some of the public hospital experience, and then also to share with you, because I know that non-invasive prenatal testing for common trisomy has been very popular in Vietnam. So I think the next question we are interested in is how about could we expand the test scope to rare autosomal disease, or even for monogenic disorder that Dr. Wu just mentioned to you. There's even some sign we can see in the first trimester. So I come from Chinese University Hong Kong, where we run the Prenatal Genetic Diagnosis Center. Literally, we do everything from chromosomal analysis, cytogenetics, microarray, whole exon, and whole genome sequencing. Of course, now everything has been moved to the next generation sequencing. Particularly, more or less, you have a sequencer. You can do things from non-invasive to all the way of a whole genome sequencing. So with that, why we have this discussion today is mainly because you can see that this is the data from Hong Kong. The maternal age for the nucleus of the those that have more than one pregnancy, you can see that there's a trend of increase of the maternal age, right? From in the old days, less than 30% to more than 42. So actually, this is already as an indication of advanced maternal age. That means they're in a high risk. So for high-risk pregnancy, most of the time the patient, they do not want to go for an invasive procedure. So the discussion today is what the NIPT can do and what is not able to do. As mentioned earlier, actually this is the system in Hong Kong. Any pregnant woman in Hong Kong, after the dating scan, actually they can opt for free first trimester Down syndrome serum-based screening, because the nucleotranslucency. Or if they are in high risk, they can also have an option to be free for non-invasive prenatal testing, but only confined it to common trisomy. Or they can go for invasive procedure, and then depends on the gestation, either CVS or amniocentesis, and then we can offer also free of service for qPCR that can detect common trisomy, or go down to the chromosomal microarray. And you can see that it takes steps, right? The first implementation of the public funded first trimester Down screening was in 2010. And because after that we understand that Down syndrome screening is not just for common trisomy, you can also have other chromosomal abnormalities. And this is why subsequently in 2019, we have implemented both as a second tier NIPT as well as the invasive test for chromosomal microarray. So the core questions and the reason is because now prenatal screening and diagnosis is not only for common trisomy. Because we have a very best non-invasive prenatal testing invented by Professor Dennis Lowe from our university that give a very good sensitivity and specificity, and more importantly, a low, very low false positive rate. But like the last two speakers has mentioned, actually we also have a group of pregnancy, they have structural abnormalities. So the question is, what will contribute to this type of structural abnormalities? If we go back to the textbook, we understand that we have 4 mutations. Common one you may know maybe for, even for beta thalassemia, or like the vasopathy, the Lunar syndrome we have seen, or because of the chromosomal microarray, as well as the tail tapping analysis, we know that there are microdeletions, like 22q11.2 microdeletion syndrome related to George, or commonly we always focus on is the common trisomy. And because of this difference of spectrums of genetic disorder, the questions in the last 15 years we are asking, can we practice one technology but able to take care of most of them? That means not just chromosomal abnormalities. Can we also detect pathogenic copy number variant? That's why the landmark study in 2012 have been shown that if we're using chromosomal microarray, we are not only able to detect all chromosomal imbalance by tail typing, but we are also able to have an additional diagnostic, particularly in high-risk pregnancy cases, like those with structural abnormality, or even for those that are just because of advanced maternal age, we have an increase of addition 1.7 to 6%. So with all this, the question is, what have we learned? By using microarray, how they're relevant to our NIPT. The first thing is, we know that based on different indications, right? Like the previous speaker, we have emphasized a lot on high glucose translucency. So glucose translucency higher than 3 mm even, you can see that the diagnostic yield by microarray is higher than tail tapping analysis. But same applies for calf-fit and pilot. That means ultrasound structure abnormality actually give a very important indication that it's not just chromosomal abnormality. There are things smaller but important that tail-tapping analysis was not able to identify. Another important message from that is that we always concerned about Down syndrome because we know that it's related with advanced maternal age. Right? For those older than 35, you have an increase in risk. But if we understand regarding like the George syndrome, actually, this microdeletion syndrome, or most of the microdeletion syndrome, they are not maternal age dependent. Okay, so if we are going to screen for Down syndrome for advanced maternal age women, how about for young age women at age of 24? Actually, to screen for Down syndrome is relatively lower risk than her possibility of carrying a microdeletion. Okay, so with that, actually, it set the stage of this talk. We have a very good non-invasive prenatal screening. We also have a very good technology that we can do diagnostic tests. So for this workshop today, we are mainly focusing on what can we do with the non-invasive prenatal testing. Tomorrow at the main conference, I'm going to share more regarding the diagnostic applications. Okay. So as I mentioned several times already, when we consider NIPT, it's because it has been known and proved to be an accurate and superior screening method for common trisomy. Okay? And should we expand it to other chromosomes or microdeletion? Why we have this question is because we are only need the same sequencing technology. We are using the same maternal blood sample. Okay? And what's the scientific question that we want to expand for genome-wide NIPS? This concept of genome-wide NIPS is not just in Asia. Actually, it has been common practice in Europe, in America, as well as in Australia. If we take two examples, these are two landmark publications from the Belgian book and the Belgian book. What I want to show you is that if we concern about common trisomy, the positive rate, actually, if you add them together, is about 1%. Right? So if you want to expand to rare and equality, that means the rest of the autosome, what's the positive rate in the general population? Actually, it's about 0.3%. Okay? And if we expand that to microdeletion, those mentions to you, actually is another 0.18. That means if we are going to expand our NIPT or NIPS from common trisomy for rare and equality and CMV, we will have another 0.5% positive rate. Okay? But what is the concern we need to understand is first, what's the population? Because as we mentioned, if we're talking about high-risk population, your positive rate will be higher. Second, what is the platform? Because the platform will affect the resolution. Are you doing the same measurement at 1 million base pair resolution, or you are still at 7 or 8 million base pair resolution? And also very important, have the method been validated, right? Is it under a accredited lab, or there's no much data you are able to see? For the practical issue, we understand that we want to detect for rare and equality because we know that like trisomy 7, 16, 8, and 5, right? They are the most common ones due to genome-wide. And they're important because, trisomy 15, right? It could be one of the main reasons for early miscarriage as well. So this is the data in general, not just from our center. You said if we do genome-wide NIPS, right? There are several chromosomes that have a higher seed, right? Chromosome 7, 8, 15, 16, and of course also 22. And actually this is all related with the CVS. Why is that? It's because we are measuring the cell-free DNA from the trophoblast for the placenta. So this is why we will have a challenge of confining the placenta size. Okay? And we know that most of these common trisomy or any of the rare trisomy, 85% of them are from the maternal meiotic origin. Only very little of them are from the parental origins. And 15 as well as 7 and 14 important because we also understand there are some other genetic disorder. They are because of uniparental disomy. That means both of the chromosomes come from one parent and they have a repeating defect. But practically, if you do whole genome on chromosome level, how true is it positive? I think the patient always asks us this, if I have a positive result, how many of the cases is really a true cases? That is positive predictive value. That is not related with the sensitivity and specificity of the company and the data that you do. Okay? So trisomy 7 is one of the ones you always see. But you can see that actually the positive predictive value is very low. It's only 3.4%. Okay? That means 100 patients NIPT come back at trisomy 7, you only have 3.4%. Less than 4 individuals. Actually, they're true positive. Another important issue we have to be aware when we practice genome-wide is that we also commonly have been noticed that, including sex chromosomes, there are maternal popular ovarians that can contribute to this false positive result. Okay, so with that, okay, the key message for you, if you're going to practice genome-wide NIPT, is that your overall positive predictive value is around 11% only. So that's why invasive prenatal diagnosis by endocentesis is very important. And also, if we look at the basics of the trisomy registry, you can see that some chromosomes, they are more related with mitotic origin. Some are more of the meiotic origin. So the NIPS performance for each of chromosomes should be evaluated specifically. Okay? So that set the stage if you are going to implement for the genome-wide NIPS. I always like to use S because it is a screening for numerical chromosomal abnormalities. How about copyright variant? Because as I mentioned, we have been practicing microarray for a long time, and we understand what's the spectrum of the pathogenic copyright variant. So I just take one example. This is an earlier paper we published. If you look at the spectrum of pathogenic copyright variant among over 23,000 cases that have been performed on microarray, you can see that yes, they are all distributed among different chromosomes. So that gives you the support evidence that we should do maybe genome-wide NIPT. But if you look carefully on this pathogenic copyright variant, 84% of them are less than 5 million base pair. I can say that most of the platform you use for the genome-wide NIPS, they do not detect anything less than 5 million base pair. Okay, so if you put this as an equation, then you are totally wrong because they cannot detect it. Okay, so that's just very important because most of the NIPT, they are at 6 million base pair. Okay, so you have to be very cautious if you're talking about microdeletion or copyright variant. So in order to prove what I say is true, this is the data from our center. We have, this is one of the 2 years data. We have performed over 28,000 cases. And among them, you can see that the positive rate, here we're only talking about copyright variant, is 0.6%. So it's very similar as what I mentioned to you. Okay, so for that, the most important thing we want to ask is, how many of them are true positive? How many of them may be contributed by maternal origin? And how many of them are not? Right? And you have to bear in mind that we are down to 3 million base pair resolution. We are not at 6 million. So if you are doing 6 million, you are never able to achieve 0.6%. You should be less than 0.5. Okay? So this is the spectrum. You can see that in terms of the distribution, they're involving all the chromosomes, right? And also, orange color is the loss, blue is the gain. So you can see that you can see more gains than losses. It's about a 2-to-1 ratio. And the most important thing, the most intriguing thing I want to share with you is that after amniocentesis, only half of them were fetal origins. There are another half of them is shared between maternal and fetal origin. So that tells you that a diagnostic test is very important. And also 14% they are mosaicism. It's not every cell contains the pathogenic copyright variant. And if you look into the size, as I mentioned to you, you can see that this is the size distribution of the copyright variant we identified from as small as 2.3 million base pair to close to 100. You can see that, as I mentioned to you, you have to remind yourself when you do NIPT, what's the resolution? If your resolution is less than 5, actually, most of them, what I report here, you are not able to detect by your NIPS. Okay? Because you can see that most of them is smaller. Although the average is 10 million base pair, but the medium size actually is 5. Okay? And the range is quite diverse. Okay? So what's the difference if you only do common trisomy compared to others? You can see that this is the overall result. If you do common trisomy, okay, actually you are talking about including sex chromosome and equality, you are talking about over 64% of the result you are able to detect. The rest of it, for the rare and equality is about 12%, and then we can also have microdeletions and others. So in terms of a public health setting, if you ask, should we do rare and aneuploidy as well as cochlear malaria. There are only at the moment 2 guidelines we can follow. One is from the American College of Medical Genetics and Genomics. The other one is the International Society of Clinical Diagnosis. Actually, both professional statements state that there are insufficient data regarding the performance and the clinical utility of rare aneuploidy as well as cochlear malaria. So they do not recommend genome-wide NIPS for rare aneuploidy as well as CNS. Okay. But how about the other spectrum, right? We see that there are so many monogenic disorders. Should we also take care of them? Because we know that each of them is rare, but we add all the single gene disorder together, it could be as high as 1 in 10 in our population. Do we have data to support that? Yes, this is from the pediatric cohort. You can see that, right? The spectrum of the genetic disorder, apart from common trisomy, right? There are other cochlear variants as well as a high percentage they are related with Mendelian disorder. So this is a group of disease, they are mainly by point mutation or at a single gene level. So can we apply non-invasive prenatal screening, or even in the UK, NIPT, non-invasive prenatal diagnostic test? The answer is yes, because this Professor Lencitti and Dr. Natalie Childers' group is one of the leading in this area. You can see that over the years, they have been helping more than 300 families with over 276 unique variants among 196 genes. But what's the cautious statement here is that they are using target approach. They are using a target sequencing. That's why it's a D. But if you look at the spectrum of disorder, right, Lunar syndrome, achondrogenesis, right, Collin-Delancey or OI, those are the very common ones, and those is very not easy to diagnose, no matter in the first or second trimester. So the question we want to ask for advancement in this field, can we also take care of this single gene disorder? Particularly for those with a high incidence, right? Like the vasculopathy pathway we just mentioned. Okay. But what's the challenge? The main challenge is we need different technology. Right? At the moment, you can do NIPS for the genome-wide, for cochlear variants. You can also, there's company that offer you single gene disorder, but they are not on the same, right? So the question is, can we do all in one? That means I do NIPS for both common trisomy, but also other important structural abnormalities. Because the focus today is fetal ultrasound structural abnormality. That's related with skeletal disorder, multi-system disorder, and even some of them is on the So actually it works because that's an early date. We collaborate with Baylor College of Medicine. We will prove that we can do monogenic disease as a PC, right? And now the question we want to ask: can I have a test? I can take care of common antibody, microdeletion, as well as a spectrum of more than 60 monogenic disease in one test as NIPS. This is a proof of principle study just published this year in Nature Medicine, and you can see that within this cohort of over 876 fetus with structural abnormalities, 98 of them have mutations. Okay, you can see that they including from common autosomal aneuploidy, sex chromosome aneuploidy, microdeletion, and 37.8% of them actually they are monogenic disease. Okay, and they are related with different fetal structure abnormalities, including those with craniofacials, brain, and skeleton. So this means that single gene and chromosomal disorder can account for 37.8% and 62% of fetal structural abnormalities separately. And the detection rate actually was improved by 67% when compared with those without the panels on it. Okay, so does it work? Actually, we also do a prospective study in the center. So in this cohort, although it's a small one, you can see that we include high-risk pregnancy as well as a low-risk one. And you can see that no matter in the high-risk one with ultrasound structural abnormality or the relatively low-risk one, apart from aneuploidy, we were able to detect pathogenic or monogenic disease, which contribute to another substantial percentage. So with that, I just want to give you a favor that there are new technologies that's coming in. We're able to do all of them. But the challenge for us in the future is that there are also new methods telling us that we can even do whole fetal exon screening on NIPS, because with this algorithm, we can detect for copy number variants as well as point mutation. But the issue for us is that should we look for everything when we do an NIPS? Should we focus more to be a cost-effective analysis that we're able to help with a particular indication location in particular test? So to summarize my talk, we believe that cell-free DNA-based non-invasive prenatal screening has the potential to replace the first trimester combined test because it's a more comprehensive first-tier test. But for targeted genetic disorder, at the moment we don't have sufficient data regarding its performance and clinical utility. These are all proof of principle studies. We need more prospective and retrospective study to evaluate the performance of detecting different chromosome and genetic disorder in different risk cohorts, because we have low risk cohort as well as high risk cohort. So this is the last slide. I just want to summarize to share with you that when you do NIPS, right, you have to first consider what's the method they are using. Okay, is it a targeted sequencing or genome-wide sequencing? Also, do they include the SNP base? Right? If they include the SNP base, you will have the possibility to detect checkpoint. If you're able to do a genome-wide, then you're able to see more. Okay. So the ideally, as I advocate, is that a new all-in-one NIPS that you can detect common trisomy, sex chromosome abnormalities, selected microdeletion, and selected gene disorder and checkpoint with the same price that's not higher than what you are practicing at the moment. So with that, I would like to conclude my talk, and also we welcome you to attend our 17th Asia Pacific Congress in Maternal Fetal Medicine, which is in November in Bangkok. Thank you very much for your attention.
Xin cảm ơn giáo sư. Và trước khi vào phần thảo luận của phiên 1 thì kính mời quý đại biểu chúng ta cùng xem một chương trình ra mắt hệ thống siêu âm Thera Z20